Good afternoon, and welcome to the Bipartisan Policy Center's webinar focusing on healthcare in our rural communities. I'm Bill Hoagland. I'm Senior Vice President here with the Center, and I work with our tremendous health staff on finding solutions to the challenges we confront on ensuring Americans, whether they be rural, urban, or frontier, have access to affordable, safe, and quality healthcare. For those of you who may be unfamiliar with the Bipartisan Policy Center, we recently celebrated our 15th anniversary, having been formed by four former majority leaders of the United States Senate, the late Senators Bob Dole and Howard Baker on the Republican side, and our Democratic supporters, Tom Daschle and George Mitchell. Our mission, challenging, of course, in these days, is to try to seek and advance bipartisan solutions to policy issues that decision makers have to face. And of course, in the healthcare sector, that includes ensuring services are readily available, not only in our urban settings, but in our rural and frontier areas of the country. I grew up on a farm in a very rural area of the country. The nearest hospital was 35, maybe 40 miles away from our farm. By the way, a farm that still remains in the family today. On a recent trip back to the farm, I had the opportunity to see once again those challenges and vulnerabilities rural hospitals face, from declining caseloads to often negative operating margins to the proverbial workforce challenges to recruit, hire, retain nurses and other healthcare employees. So no surprise, I paid particular attention to the work of our health team as they focused on the impact COVID had and is still having on our rural hospitals and what is yet to come. Last month, we issued our year-long review with rural hospital leaders from 8 states: Iowa, Minnesota, Montana, Nebraska, Nevada, North Dakota, South Dakota, and Wyoming. The BPC report presents a series of recommendations in 4 broad areas. The first being providing some immediate relief to stabilize rural hospitals, such as eliminating the sequester that they face until at least 2 years after the public health emergency ends. The second area was to strengthen rural healthcare delivery transformation, such as through the Rural Emergency Hospital, or REH model, which becomes available to rural hospitals next year. The third area was addressing the workforce issue, including maybe streamlining the licensure requirements. And finally, the fourth, securing greater access to virtual care in rural communities through telehealth services. And on this latter issue, we are issuing an additional short report today entitled Leveraging Digital Technology to Enable More Equitable Distribution of the Healthcare Workforce. We're going to hear from hospital representatives from 2 states in our earlier study, Minnesota, Nevada, and other experts from the University of North Carolina, Chapel Hill, and the RAND Corporation. But before going further, let me give a shout out to the BPC Health team, who have devoted so much time to this work, led by Marilyn Serafini, our director, Sabat Bhatnagar, Julia Harris, Tara Hartnett, and our consultant on this project, Nylene Rubin. So without further ado, let me introduce our moderator for our discussion today, Sarah Jane Tribble. We are so lucky to have Sarah with us this afternoon. She's an award-winning senior correspondent at Kaiser Health News, covering the state of healthcare in rural America. One of Sarah's most recent stories, which I have yet to read but will read, Sarah, was entitled Buy and Bust, When Private Equity Comes to Rural Hospitals. So Sarah, I'm going to turn this over to you now.
I'm on mute. Sorry about that, guys. It's good to be here. Thank you, Bill, for having me. And thank you, BPC, for putting out this incredibly important report and for putting together this panel today with these great panelists. We're talking about rural healthcare. I've been a reporter for the better part of the last few decades, and much of that has focused on healthcare. More recently, I've been focusing on rural healthcare. I've been asking the questions about people who are struggling to survive in rural areas, and not only asking those questions and writing those stories, but also asking what it takes for those folks to thrive. In the past few months, Kaiser Health News has launched its Rural Health Desk. We have reporters across the nation, and we have a desk completely focused on rural healthcare. As we were doing this desk and creating it, and I began my reporting and talking to folks in the field and putting together stories, this is about the time when I started to hear about BPC's report. The topics that Bill mentioned are the top topics that are on the minds of rural healthcare providers today: telehealth, closures, staff shortages, and we get to talk about them today with our panelists. I'm going to let them introduce themselves so that they can talk a little bit about what they focus on. And with that, I'm going to hand it off to Lori Usher-Pines to begin with.
Hello, welcome everyone. My name is Lori Usher-Pines. I'm a senior policy researcher at RAND, and RAND is a nonprofit research organization, if you're not familiar with it. I've been focused on telehealth and its impact on access, quality, and cost since around 2014. And it's interesting, at the time, I thought that telehealth had a lot of promise for emergency situations, for public health emergencies. And that's what initially interested me in getting into this topic. And here we are with COVID. And as we know, telehealth is proven to be an extraordinary tool for this public health emergency.
Joan, why don't you go next?
Thank you. I'm Joan Hall. I'm the president of the Nevada Rural Hospital Partners. It's a consortium of Nevada's 13 critical access hospitals. 7 of those are truly frontier. Our members serve only 10% of Nevada's population, but in 90% of the landmass. That is over 95,000 square miles. Our hospitals are as far away as 215 miles from the nearest tertiary hospital. So we're far and distant. 7 of our hospitals also have distinct part long-term care. I think that really plays into some of the COVID issues and the staffing issues for us. So really excited today to have this conversation. Thank you for inviting me.
Great, thank you. And Joe Schindler with the Minnesota Hospital Association.
Well, good afternoon. My name is Joe Schindler, and I am the Vice President of Finance Policy and Analytics at the Minnesota Hospital Association. I've been here for 35 years, and so I've seen a lot. We represent over 135 hospitals that are not-for-profit across the state of Minnesota, including 78 critical access hospitals. And rural is especially near and dear to my heart, just like it is to Bill's. I grew up in southern Minnesota. I saw, at least during my career here at MHA, the local hospital did close. And so I saw what impact that has on a local community. As such, I do staff our small rural committee, as well as a rural transformation council that we formed a couple of years ago. Thank you.
Great, thank you. And then last but certainly not least, I think everybody knows him, George Pink.
Yes, good afternoon. My name is George Pink. I'm Deputy Director of the North Carolina Rural Health Research Program at the University of North Carolina, Chapel Hill. Most of our work focuses on rural hospital closures, financial distress, and the new rural emergency hospital model.
Great, thank you. Before we get officially started, I want to just remind all of the folks watching us that they can post questions using the live chat on YouTube, or they can tweet to hashtag BPC Live. So feel free to do that, and we'll be looking at questions as we go on throughout the panel. To begin with, I'd like to start with one of the hottest topics that was ongoing before the pandemic and seemed to sort of take a pause during the pandemic. It's rural hospital closures. This is highlighted in the BPC report as well, with some numbers and facts that you'll want to go look at. But during the pandemic, the closures dropped to just 2 in 2021, 2 hospital closures across the country. The year before that, a source tells me that they had hit a 10-year high of 19 in 2019, or no, I'm sorry, in 2020. So on that note, I wanted to kind of start with George, whose research facility keeps track of these numbers and is a go-to source, has been for many of my stories. George, what happened during the pandemic to slow down these closures so much?
Yes, several factors stabilized rural hospitals during COVID-19, but three really stand out. First, and most important, the federal government provided enhanced financial support for hospitals and other healthcare providers to compensate for revenue loss and the higher costs associated with the pandemic. The primary support came from provider relief funds and the Paycheck Protection Program. The estimated distribution of provider relief funds to rural hospitals was almost $15 billion as of February 21st. And this funding really allowed many hospitals to survive during the pandemic and probably prevented many of rural hospitals from closing. Secondly, Congress placed a temporary moratorium on the sequestration reductions, which are the automatic scheduled payment reductions of 2% on all Medicare services. Third, Congress provided for enhanced payments for telehealth services rendered during the pandemic, which was particularly important for rural providers.
I want to come back to that telehealth later and some of the other topics. But as we go forward, I was talking to somebody last week at a national organization, and they said that they expected hospital closures to return, rural hospital closures to return with a vengeance in the coming years. What are the challenges, George, that these hospitals face, and why would we expect that?
Yeah, rural hospitals face many, many challenges, most of which predate COVID. Just think about the operating reality of small rural hospitals. They serve populations that are small. They have more people who are older, sicker, lower income, unemployed, uninsured, underinsured. They have low patient volumes and revenue that often doesn't cover the fixed costs of maintaining a 24-hour emergency department. They have a payer mix that has a greater proportion of Medicare and Medicaid self-pay patients. They have difficulty recruiting and retaining physicians, nurses, therapists, coders. They have lower access to capital. I mean, I could go on and on. Consequently, as the Bipartisan Policy Center report states, long-term unprofitability is just a fact of life for many rural hospitals. In the 9 years before COVID-19, the median total margin of rural hospitals was on a downward trajectory. The percentage with a negative total margin was increasing. There's no doubt that the COVID funds were a financial lifeline for many rural hospitals, but the COVID funds are temporary and will soon be fully distributed. So unless Congress authorizes additional funding, we expect rural hospitals to return to pre-pandemic levels of profitability. In fact, profitability could decline even faster because of what hospitals are now having to pay for labor, particularly nursing, and because reimbursement increases are just not keeping pace with expenses.
Thank you for setting that national stage for us. I know that we have some folks who talk to hospitals and providers every day, Joan and Joe. We've heard a lot in the last couple of years on a national level about staff shortages, some of the financial distress, some of the federal relief and what they've done in contrast, and just the strain that rural hospitals have been experiencing as they face the pandemic. Can either of you, both of you, give us an idea of what you saw helping your specific hospitals in your states?
Sure, this is Joan. I'll start. As George said, the relief dollars we got from the federal government were truly a lifesaver. Our increase in supplies, those costs were so escalated, it was amazing. Even though we belong to a group purchasing program, you only got a 10% of your allocation because supplies were at such a need everywhere. And so if suddenly rural hospitals had to buy more, you had to buy off contract, we could never have afforded that without those relief dollars. The staffing, I know we're going to talk about later, was that cost escalated so much, at least in Nevada, that without those federal dollars to replace that and to enable our hospitals to continue with the staff they had, especially with the revenue loss for outpatient services that typically we provided, and everything kind of squoze down during COVID, in addition to that, the different type of process we had to provide. We had to have testing sites set up. In 7 of our communities that my members serve, the hospitals are the only provider of healthcare. The only doctors work for those hospitals. And so there wasn't a lot of staff to do all this. And so setting up testing tents, setting up care for these patients was very difficult and actually took more staff than less staff. And so those federal dollars that we got to help us set up those systems was very important. Also, 7 of our hospitals have distinct part skilled nursing facilities. And for those processes, to follow CMS and CDC processes was pretty phenomenal for smaller skilled nursing facilities. So without those federal dollars, we would have been in dire difficulty. And I think to something that was said, you know, what's going to happen in the future, I think that that's also still a scary point.
And I would just piggyback onto that to say that first and foremost, what we saw was that our everyone from our front lines, clinical staff and administrative staff, all the way to the CEOs and administrators, really had to change their work process and how things were done within the hospital walls. As Joan so eloquently outlined, they had to rearrange how they delivered care and create the testing tents and so forth. And there was a lot of unknowns in the beginning of the pandemic. Now, the knowns that we knew going into the pandemic were that that rural hospitals were suffering financially for some period of time. And we documented in our 2020 report of financials across the state of Minnesota using audited financial statements. The median operating margin dropped to 1.2% after, which represents a 3-year drop in this median operating margin. So we knew that there were troubles going into the pandemic. Certainly the financial supports provided by the federal government, which by the way, were fairly speedy, and that was very helpful. We estimate our hospitals, at least on the direct provider relief funding, received about $850 million. And that was paired with some state funding of somewhere in the neighborhood of $150 million. So we estimate our hospitals received about $1 billion in financial relief. And that was extremely helpful. I think that provided some support while they were scrambling in every way possible to take care of patients.
I'm curious, in each of your states, how many of your hospitals, because they're small rural hospitals, before the pandemic saw 3 patients or less a day? And what did that possibly surge to? How did the pandemic affect that?
Well, I'd say that of our 78 hospitals, probably, I don't have that number right in front of me, but probably 40 hospitals have an average daily census of less than 3. Some of that is related to observation care. And so now going into the pandemic, during the surge periods, what was interesting was that many of our rural hospitals were operating at full capacity. And part of the reason being that many of the COVID patients that came in were very, very sick, number one. And many of the tertiary centers, referral centers, were actually full. The ICUs were full, the med surge units were full. And so in many cases, and we had a coordination center within the state to help coordinate transferring patients across hospitals, because it became a bit of a nightmare to know where beds were available. So what that meant was that many of our rural hospital providers had to provide care in place for many very ill COVID-19 patients, and they did it very well. So that was actually something different than what we had seen in the past, which was like, as you mentioned, lower inpatient census. We have probably 10 to 15 hospitals that have an average daily census of 1 or less.
Yeah, so that provider relief money probably really helped them prop up those extra services they needed to provide. We have a question from the audience I want to throw in here, and maybe Joan can help answer it, or George. And that is, can small rural hospitals survive now without more federal relief money? And what's the possibility? I think this is kind of the key part of the question. What's the possibility of getting more federal relief dollars right now?
Well, I will just chime in and say that we hope that there's more federal relief dollars. Not sure that there will be, because there are, as to the previous question, when Joe was talking, we have 5 hospitals that typically have less than 3 inpatients per day. And the same during the pandemic, we saw hospitals, we had to get special approval from the state of Nevada to go over our bed capacity. And we had 4 hospitals that were over 25 beds throughout the entire pandemic. So they were really stretched. Those are the ones with ICUs. Those without ICUs were also stretched. As Joe said, we couldn't get patients to tertiary hospitals that needed that care. So it really stretched what rural hospitals had to provide, and had the capability, because we couldn't get patients transferred any place in state. So, and transportation for out of state transfers was also an issue for Nevada. So back to the question about, can we survive without increased money? I think that is something we're very worried about. We're seeing still sicker patients, patients with different kind of needs that typically we've not had to provide care for in rural areas. And still in Nevada, I was just on a call with the Hospital Association. We had last week 600 patients from tertiary areas not being able to be moved within the system because long-term care or skilled nursing can't accept patients. Home health care for Nevadans seem to have dried up. So tertiary hospitals are still clogged up, and which then clogs up the pipeline for rural patients who need a higher level of care.
I think that's a great way to bring in some research that Lori has done and some knowledge that Lori has on telehealth. And during the pandemic, not only do we see the PPP, PRF funding, COVID-19 funding, we saw some money being thrown at telehealth. A lot of new programs before the pandemic began. We didn't see that quite so much. So I wanted to, ask, based on your research, Lori, you had a great report out last year. What are some of the key areas that did expand with funding under the pandemic when it comes to telehealth?
Sure. So regulation was relaxed across the board, both for urban areas and rural areas as a result of the pandemic. I think I just wanted to bring in an important point for context when you think about telehealth utilization. So prior to the pandemic, rural Medicare beneficiaries used telehealth at relatively low rates, but their utilization rates were higher than urban areas. And a key reason for this, that telehealth in rural communities was reimbursed by Medicare, but for urban areas, with a few minor exceptions, telehealth generally wasn't reimbursed. Before the pandemic, about 80% of telehealth visits in rural communities was for mental health conditions. And most telehealth visits occurred in outpatient clinics. So patient would present in a rural community to an outpatient clinic and maybe receive care from a remotely located specialist. So much less utilization by rural hospitals than in outpatient settings. When the pandemic hit and utilization increased exponentially, both in urban and rural communities, things flipped. And that's something that's really interesting that we're seeing. During the pandemic, we're seeing lower utilization of telehealth in rural areas compared to urban communities. A 2020 ASPE analysis of Medicare data showed that urban beneficiaries had about 50% higher utilization of telehealth than rural beneficiaries. So a key question you might be wondering is, why is this the case? Some experts say it's because of the digital divide and the fact that as a third of rural individuals don't have access to reliable broadband. If you bring in affordable broadband, it's probably even a larger proportion. So that's a key point. But our study team at Rand and Harvard actually recently interviewed 20 CFOs of small rural hospitals to understand what their perceptions are of the impact of telehealth on hospital finances. And a few other interesting theories came out in that work. Some expressed that there's a real preference for in-person care in certain rural communities and the personal connection that comes with in-person care. And a few CFOs told us that they were concerned that they would actually lose patients if they heavily invested in telehealth, because in that case, they're competing with large urban hospitals who also offer telehealth. In other words, you can get telehealth from anyone, but it's that in-person care that's really rooted in the community and delivered within the community. And then just on this point about services that are more popular during the pandemic, the rural CFOs that we spoke to mentioned that during the pandemic, the most common hospital-based telehealth services included telestroke and tele-ICU. They also reported multiple ED-based telepsychiatry programs. Then on the outpatient side, we heard of many examples of telehealth for specialty behavioral health services, and also cases of rural health clinics offering primary care. So they're serving as distance sites and serving patients in their homes. So telestroke, telebehavioral health, these were common features in rural communities prior to and during the pandemic, but there's this interesting shift now with rural health clinics. They were not reimbursed for telehealth. They couldn't serve as distance sites prior to the pandemic, but now there seems to be a lot going on there. And the BPC report talks a little bit about this in their recommendation, saying that they should permanently be allowed to serve as distance sites. We are seeing a lot of interesting activity there.
And another thing mentioned in the BPC report is the audio only access. And I think it was funded during the pandemic, and now Medicare may not fund it. Is that correct, Lori?
Sure. So there was very limited reimbursement for audio only visits prior to the pandemic. During the pandemic, audio only visits are reimbursed by some payers at parity to in-person and video visits. There's already been permanent policy changes showing that audio-only visits can continue to be used for behavioral health services in Medicare. Its fate is more uncertain for other populations and other conditions. So we are seeing some permanent policy on the behavioral health side for audio-only.
Okay, there are also calls for permanent policy or changes when it comes to some of the other Medicare funding programs. And I know we're going to talk about rural emergency hospitals here in just a minute, but before we get to that, I'd like to set the stage for some of the programs that are in place right now. These are programs like the Medicare Dependent Hospital Program, things that may not have the extension at the end of this year, I believe. And I wanted to turn to the hospital experts on our panel, Joan, Joe, and George, to talk a little bit about some of those Medicare programs that are coming to an end right now and what that means for the rural sector.
Well, just to start out, I'd say we've got a number of rural hospitals that currently are in those programs and have been for a number of years. So they've become used to those funding mechanisms and support. So to end these programs would be disastrous for those hospitals. And so anything we can do, this is the worst time probably to pull the rug out on programs that have helped us support rural access for many of those hospitals that need those supports.
And the Medicare payment program it expires in October. And is there another one that's going to affect your hospitals, Joan?
Our hospitals aren't that impacted by those types of services, but the telehealth issues were very beneficial during COVID. As was stated, the RHCs being a distance site was very, very important, although then we did recognize that we couldn't reach all of the beneficiaries that needed that because of the bandwidth issue. So that is really important to us, as is the behavioral health telehealth.
And we will get to a little bit more in depth on telehealth in a few minutes. I do want to address sort of the big white elephant in the room when it comes to when I make calls out to sources, and it's a big topic in the BPC report, and that is the Rural Emergency Hospital Program that was approved by Congress in 2021, I believe. This is a program that has been under development in various ways for years. I know lots of lawmakers and policymakers have talked about a new program for rural hospitals. The last new one was the Critical Access Program, and that was 2 decades ago. And so this is sort of big news. It's supposed to go into effect in January 2023. And basically what it says is that small rural hospitals, critical access or acute care hospitals that are 50 beds or less, can convert into basically rural emergency hospitals. They're required to have an emergency department. And actually the proposed rules aren't out yet. And so there's a lot of confusion out there about what to expect. So, the BPC report has recommendations on this. George, your group did a fantastic study last year on how many hospitals would be converting to this REH program if it was proposed and put into place. And I wanted to ask you to talk for a moment about that analysis that you did, what you had anticipated seeing, and whether that still holds true today.
Yes, thank you, so Jane. Last year, the North Carolina Rural Health Research Program, we produced a study that estimated, using sort of 3 simple assumptions, that about 68, 70 rural hospitals might be interested in conversion to the new rural health rural emergency hospital model. Since that study, like the Bipartisan Policy Center, we have talked to many people from state offices of rural health, hospital associations, small rural hospitals themselves, rural emergency physicians, consultant, and others. And what we've heard is that the people are estimating the number of hospitals that might convert ranged from 0 to 200. I'm a finance professor, so you won't be surprised when I say that I believe the number of rural hospitals that ultimately decide to convert to REH will be strongly influenced by the money. Is there a financial case for conversion to REH? That is going to be an extremely important question.
Yeah, I think one of the questions in there is what that federal payment will be. The proposal is for a bump in Medicare payment overall, and then what's the federal payment? It's mentioned in the proposal, but nobody knows what that calculation will be. And whether it's $750,000 or $3 million as a fee to those hospitals is going to make a big difference, from what I understand, and who joins. Joe and Joan, in your states, say 2 years ago when you first heard about this, what would you say the uptake would have been on the REH? And now what are you hearing out there, and why the change?
So in Nevada originally, and still, there were 5 hospitals, those with the very low volume, inpatient volume, that have expressed interest. It's kind of, it's an up and down thing, waiting to see really what that finance looks like. What is the reimbursement? And some other issues very important to our members. Can you keep your distinct part long-term care? Can you keep your swing beds? Can you continue to participate in the flex and chip grants? Because that is so important to our membership. And if you did convert and then found out, this wasn't working, or your community said, oh my gosh, we want inpatient care, could you convert back easily? So those right now are the biggest stumbling blocks, besides the finance, that my members have expressed, and that I don't have the answers. I don't think those answers are out yet.
And yeah, Joe, what are you hearing?
Yeah, what's interesting is we haven't heard from any one hospital that has stepped up to say we're interested in this. Now, we have had discussions in our Rural Transformation Council about various options for maintaining rural access, and what would some of those options be. There are a lot of questions, as Joan outlined, with the Rural Emergency Hospital program, which so I would say a lot of our members are cautiously looking at this. There is the finances that have to be worked out. There's also the perception of the community. Certainly you'd still maintain an emergency room and outpatient services, but just closing down inpatient beds is no easy task. It's like closing a school almost, except you're keeping part of the school open. So it's a tough thing in rural Minnesota. And the question is going to be, will the financing be a tipping point or not? Again, with so many questions, I don't think we have anybody lining up at this point in time. And given the rules are coming out so late, I don't know how the 2023 timeline could possibly be met by any one hospital. But so that's what we're looking at. If there are some good financing and flexibilities incorporated into the program, then I think we would have some hospitals looking at it.
Yeah, my understanding is those rules are coming out so late that states do have to pass licensing procedures for this, correct?
Mm-hmm.
Okay, I see George shaking and everybody's shaking their head. There's licensing procedures. There's questions about what kind of observation care may get the bump in funding, from what I understand. I'm looking to George and Lori on this, but there's ambulance services, telehealth, behavioral health. Those are all the things that are mentioned by folks out there when they talk about the REH program and what they're worried about, whether it'll get funded or not. There's some recommendations on this in the BPC report, but when it comes to what the policymakers, as they're hammering out over at CMS, what they're doing, what are the challenges, George, Lori, that you guys see them facing right now? Let's go ahead and start with George.
I'll focus on the financial challenges, and the first and foremost is the size of the additional facility payment. CMS pays most hospitals for Medicare patients using prospective payment methods. However, CMS pays critical access hospitals for Medicare patients using cost-based reimbursement. This is kind of technical, but it's important that the proposed method for calculating the facility payment is the difference, the average difference between what CMS actually paid to critical access hospitals using cost-based reimbursement and what they would have paid if they had used prospective payment methods. So calculating the additional facility payment is a major challenge for CMS, and it's really consequential because the size of the payment may be really the critical factor in the number of hospitals that decide to convert to REHs. In addition, for outpatients, CMS is going to pay REHs the standard prospective payment rate plus 5%. But the specific outpatient services that are covered by that enhanced reimbursement are not yet defined. For example, the BPC report lists wellness and preventative care, mental health, substance use, opioid use, oral health, and those kinds of services that we don't know what they're going to be included yet. There are many other financial issues to resolve, such as how state Medicaid programs are going to pay REHs, where they're going to get capital from in order to make physical changes to the building and so on. But there's just too many to list. I'll stop.
Don't forget 340B program, whether the 340B program will be acceptable at these REH hospitals. That's a federal direct discount program. That's not there. Across the board, when I'm talking to folks out there, I hear what Joan and Joe are saying about some of the outpatient services, telehealth. Lori, are you hearing telehealth as kind of a thing that needs to be laid out for policymakers when they create that REH program?
So our research largely shows what Joe has already talked about. When we talked to hospital leadership several months ago, not many of them were very aware of the REH model. They hadn't really brought it up yet in strategic planning discussions. And those that did were concerned about losing inpatient services. I think that things have changed in the past few months. There's growing awareness, but that's something that we saw earlier on.
And before we stop talking about the rural emergency hospital program, something you said, Joe, really, I think I just want to pause for a moment and really acknowledge that. And that is selling this to the communities as a feasible and something they really maybe should convert to. Is that even a possible talking point after what we heard about the surge in use of these hospitals during the pandemic?
Well, that's exactly the conundrum that we face is what happens when the next pandemic hits or another surge hits? Can you reactivate those beds? That's a question. Also, it's rural providers are very complex and they're supporting, I think George touched on this, They're supporting ambulance services, and so did Joan. Ambulance, skilled nursing, long-term care, home health, hospice. I mean, so there's any number of services that the hospital system just within a community is supporting that that comes into play with this as well. So it's sort of a complex financial matrix to try and work through. And the perception, again, being, you mean I can't be admitted to my local hospital? It's bad enough when you can't have a baby at your local hospital, which many rural hospitals have had to shut down maternity services because they just don't have the volume to support quality outcomes. So that's a tough thing to swallow. It would be even tougher if grandma couldn't be admitted to the hospital for her pneumonia.
Yeah, one of the big questions I was getting from folks when I called Kansas, Texas, and other places was, can we have observation beds? Can we have those swing beds? And that's exactly what Joan mentioned, is can we have those swing beds? And of course, a lot of these hospitals operate with long-term nursing, skilled nursing units as well, and whether those are there. So this idea of just eliminating the inpatient bed seems to be very tricky. I think it'll be really interesting to see when these proposed rules come out, which I know that CMS is still working on because I've asked them that question. So let's find out what we find out when it comes out. At the same time, let's shift to rural workforce, because when we talk about staffing these beds, the challenges of the workforce seem to be primary, and they were there before the pandemic. They seem much more severe since the pandemic. We've heard of burnout. We've heard of staff leaving. There's the figure that more than 100,000 nurses stopped being nurses in the last couple of years. And of course, Joan mentioned the contract nursing prices and the cost of those. The BPC report highlights some of the things that I've heard from some of the larger health systems when I've been out sort of kind of introducing our rural health desk at Kaiser Health News. I've talked to a few of the health systems that have numerous hospitals across the US. And they talk about things like, changing the licensing so that Medicare can reimburse in a different way, expanding the waiver programs, and, making sure that behavioral health is reimbursed and some of the licensing around that. Those are all mentioned in the BPC report. Are these the things that we are hearing from local hospitals in Nevada and Minnesota?
In Nevada, certainly. We did a point in time assessment of nursing need in our state at the 1st of June. And because we're critical access and have small volumes, the need is about 466 registered nurses, and currently we have 317. This is aggregate through our 13 hospitals. That's a 30% vacancy rate. And only a third of that is filled right now by agency staff. So there is a huge need for nurses and difficulty finding them, especially in rural areas. It was always hard to recruit. So finding them now is very difficult. For LPNs, we have a 40% vacancy rate. CRNAs and CNAs and infection preventionists equal to that. There is at least 10 to 20% vacancy that has gone unfilled. And so it is a great concern. And that's just for nursing. We've lost doctors as well. We've lost rad techs, lab techs. Everybody is just going, oh my gosh, housekeepers and dietary staff going, this was really hard to work in this environment during the pandemic. And so getting those individuals back is truly a challenge. And I think that goes to the REH. If you didn't have an inpatient, you wouldn't need those staff. But then when you do need those staff, they definitely aren't there. So a real conundrum for us.
Yeah, during the pandemic, we did lose across the board. I would say from nurses to doctors to environmental services to CNAs, across the board is what we heard the loss to be. Statewide, the state of Minnesota estimates 40,000 people left healthcare jobs in Minnesota, which is about one fifth or 20% of our entire workforce. So we've got a gigantic challenge in front of us. If you ask our hospitals, it's the number 1, 2, and 3 strategic imperatives is to retain the staff that they have, and the pipeline has even dried up from the education standpoint. So we've got a lot of work to do to rebuild the workforce, and so we are doing everything that we can to. I know that our hospitals have paid extra bonuses and incentive pay and provided more PTO and lots of things to encourage the workers they do have to stay. Hopefully we get back some of the workers that went off to do agency work, and we get some of those back. But we've got some concerns about, first of all, the birth rates are down. So in long term, the future doesn't look so great. And then immigration policies, if they could be expanded, could maybe help mitigate some of this.
Yeah, some more active recruiting with the visa program and pulling in not only physicians, but perhaps nurses and other folks into those communities to help with the shortages. I've heard of that. We have a question from the audience. I want to make sure I get a couple of these questions in. This one is: tertiary hospitals are under great strain with worker shortages, wage inflation, and the inability to get patients into nursing homes. And that's tertiary hospitals. And the question is, if rural hospitals close, where will the patients go?
I think that's a great question, something that we worry about always. And as I said earlier, during the pandemic, we faced that. We had to keep some of those patients that were really way above our capability. And still today, it's affecting us in Nevada because we can't get those sick patients to tertiary hospitals for the very reasons that were just cited. One thing that Nevada has looked at, and our interim finance committee approved using $20 million of ARPA funds to fund reimburse for hospitals who hire nurse apprentices. So we'd done a study. There's like 900 nursing students in Nevada, and only about, I think they said 10% of those were employed by hospitals to work as a nurse apprentice. You can only work to the level of the skill that you've learned in school. So it's not an end all be all, because they can't do everything, especially in their first semester of nursing school, but it reimburses those hospitals for hiring those nurse apprentices, trying to really solve those barriers to the pipeline. And so we just started that. So in 3 years, we'll tell you if it worked or not.
So that kind of dovetails into another question is, and do you expect the provider shortages, whether it be nurses or doctors or other providers, to be more severe, get worse after the pandemic? And are residency programs the answer, or waiver programs, a combination of those?
I think we all hope that they are. I think that we're grasping at whatever's out there. I think also in Nevada, and Joe, I don't know what you're doing in Minnesota, but we're looking at more team nursing. We're looking at delegation by nurses to others who are unlicensed, EMTs, unlicensed totally people just in there, kind of like the old days with the orderlies and the candy stripers. Go answer lights, go maybe make a bed, do things that take skilled nurses away from the bedside.
Yeah, I've definitely seen that we've employed this team approach for many years now, but the fact of the matter is the team needs to be built up too. And I think Joan touched on it a little bit, is especially acute for some reason are the lab techs, surgical techs, OR techs, all these tech positions, to the extent that we've got hospitals who are taking some of their internal staff and encouraging them to go to school, and they'll pay for all of their schooling to get those degrees so that they can bring them back and fill some of those gaps that they have. So it's to some extent, hospitals are doing what they can to grow their own to support getting more people into those positions. And I would say with CNAs, they take as many CNAs as they can and train them up to be LPNs and RNs. They'll pay for that schooling to get them through the program. It was happening before, but I think they're going to try to accelerate that as much as possible, because as I mentioned, we are working with the school systems in Minnesota, at the higher level education down to, as we talk to the HR representatives on our workforce calls, they talk about reaching back into the grade schools to see what students are thinking about in terms of healthcare careers. It's getting that desperate. So, we're trying everything that's available to us.
Joe, to that point, in Nevada, it's the same way. The AHECs are looking at K through 12. They're getting into the school districts early, talking about healthcare careers, trying to impress that upon these individuals. And one other point you made about the CNAs that from a federal policy level that I've heard a lot about is for skilled nursing facilities, if you've had a survey and you have findings, they can take away your ability to be a CNA class. You teach to educate for CNAs. And so that's kind of a double whammy. You have had a finding and now you will have even less staff because you're not able to have those CNA classes. So looking at changes in that federally is, I think, happening right now. I'm not sure it's getting a lot of traction, but that's a huge concern for especially our very distant sites, that there aren't any schools or any education for CNAs besides the hospitals.
It always stuns me. I've been doing this reporting a long time, and it always stuns me when I hear yet another program affecting rural providers in America that is affected because of federal funding, right? When it comes, it's across the board, education, staffing, and Joan, you just surprised me with another one. So thank you for that, for enlightening me on that. One of the topics that's been very hot when I talk to folks about workforce shortages in rural America is telehealth. That keeps coming up. It's been a hot topic this past couple of years. We talked a little bit before about the increased funding in telehealth during the pandemic. Before the pandemic, Medicare telehealth funding was very limited. During the pandemic, Congress allowed, home access. They allowed lots of other aspects of telehealth to be expanded. Lori, you, in your report that I mentioned earlier, you had this really great turn of phrase high up in the report. You were kind of saying that it was not the same as a genie in the bottle. All that funding, and people had predicted that the genie was let out of the bottle. Everybody would adopt telehealth. And I love that image because, when I talk to folks out there, it sounds more challenging getting telehealth online. Throwing dollars at it is not going to be the only solution, it sounds like. In your report, I'm kind of curious what changed over the pandemic and where do we go from here, just to sort of forward our conversation from earlier.
Sure. No, so we hear a lot that the genie is out of the bottle, but I might argue that what happens to the genie really depends on what happens to reimbursement and regulation going forward, right? That it's a big open question. And CFOs in rural communities told us that they're reluctant to really optimize their telehealth services or invest in telehealth until they understand what's going to happen with permanent reimbursement. So this kind of gray area that we're in now, where we don't really know what the fate of different telehealth programs will be, I think that might be stifling innovation and investment in telehealth. So, one thing we often hear is that policymakers need more evidence in order to craft permanent policy. They need to understand the impact of telehealth on access, quality, and costs before deciding where we should go from here. And so I think a real key question for the research community and for practitioners is to what extent is telehealth increasing utilization and leading to greater costs versus substituting for in-person visits? We saw that early on in the pandemic, telehealth visits were substituting for in-person visits. People were opting for telehealth instead of coming in, to control the spread of COVID-19. But whether that remains is unclear. And the more it appears that telehealth is additive and it's being used as a complement to in-person care rather than a replacement, the more guardrails policymakers are going to be interested in implementing. And what I mean by guardrails, things like limiting visits to established patients, requiring in-person visits with some frequency, or having originating site restrictions. There are a lot of other guardrails on the table, but those are some of the things that payers are thinking about. It's important to do ongoing research on quality, access, and equity as well. Those are really key, and a lot of good work is coming out. At the end of the day, some of the results of those studies may be used to justify guardrails that are primarily about containing costs. So that's just one thing to keep in mind. A few research questions that I think will be really impactful for policy discussions going forward. One thing we really want to know is, where does telehealth really save money for the healthcare system? And that can include downstream effects. It's not just how does an episode of care that incorporates telehealth compare to one that doesn't. It's, at the end of the day, after months or years of implementation at the population level, are we seeing impacts on hospitalizations, on ED visits, some of these more downstream, longer term impacts. And then also, where are the areas where there's so much improvement in quality and outcomes as a result of telehealth interventions that even if telehealth is costly, the benefits exceed the cost. So there really is a value proposition. And in cases where we see this, these use cases can be singled out for more generous reimbursement and fewer restrictions on use. So just a few kind of key research areas going forward.
I wish we had more time to spend on that. We are running out of time. There was a question in the chat about disabilities and telehealth and some of the added things. Thank you for mentioning some of the guardrails around that, Lori. There's more in the BPC report. There's more that Lori's researched. We've only got a few minutes left, but I did want to end with one final question. If our wonderful esteemed panelists could kind of think of one quick answer to it, and that is, what can Congress and state legislators do to help rural hospitals survive long-term in addition to their increased funding? We'll start with George because he always goes to finance. So let's see what he says Congress and state legislators can do aside from increasing the funding.
Well, I'm going to disobey your instruction and say increase funding. and basically what I mean by that, there's the critical access hospital program, the annual increases that are allotted to it, the rebasing of the Medicare dependent hospital, the sole community hospital, the renewal of the low volume hospital program. I know it's not very exciting, but technical adjustments to existing funding formula can make a huge difference.
Thank you, Joe.
Oh, I agree. Also, I think we've recognized, at least in Region 9, the difficulty of getting cost-based reimbursement from Medicare Advantage plans, which just seems so contrary. It seems that they're a Medicare plan. We should get the same reimbursement, and we struggle with that. I think the other thing is recognizing the access, recognizing the importance, really placing importance, federal importance on critical access hospitals, rural hospitals to access to care.
Joe?
Yeah, and I would just modify George's thing to say smart funding. I mean, these are smart funding ideas, and if there's one thing we learned in picking up on what Lori was talking about as well, on the telehealth side, mental health, the second pandemic was really the mental health challenges that we had going in and that were exacerbated during the pandemic. What would we do without telehealth, and what could we do with telehealth to prevent some of those hospitalizations that are occurring now that could otherwise be prevented or curbed with better use of telehealth and the reimbursement that goes along with it? That's money well spent. That's lives saved.
And Lori?
Great. Well, a few thoughts that the BPC report picks up on in many of its recommendations. I think a key thing is to prioritize ensuring access to reliable and affordable broadband for rural residents. Many CFOs told us that they were not forecasting big changes in their outpatient telehealth programs, where they're delivering telehealth services just because of lack of broadband infrastructure in their communities. And that's something that they want to do, but they just don't feel like they can at this point in time. So really prioritizing
that.
Yeah, FQHCs as well as rural health clinics to service distant sites. That could be key to access going forward.
All right, so money. They need more support in rural America and targeted support. I think we're out of time, and I want to just thank the BPC for hosting this panel that's incredibly important. We didn't get to a lot, so please look at that report if you can, and read stories about rural healthcare, because reporters are out there working hard to provide it. And most important, listen to folks like Lori, Joan, Joe, and George. Thank you so much, each of you, for being part of this panel, and thank you to the audience for joining us.
Thank you.